Right, good. So we're going to now move on to scanning for abdominal wall blocks. We'll start with the rectus sheath because it's in the midline. It's probably the easiest image to get, and we can often work out our orientation from the rectus. So it's really simple. A probe that's orientated. So I'm going to tap there. So on the screen, left of the screen is going to be medial, and right of the screen is going to be lateral. If I place the ultrasound probe, I'm going to be looking for an obvious muscle. So you can see subcutaneous tissue at the top, and then slap bang in the middle of the screen between 1 and 2 centimeters, we have the rectus muscle. If I move medially, we can find the linea alba in the center, and then laterally to the other side, we've got the rectus muscle on the other side. So for a rectus sheath block, we could either perform it in this with probe in this orientation, horizontally, moving either medially or laterally, and we want to deposit the local anaesthetic on just above the posterior rectus, separating the muscle off. So it's not between the tram lines like you would classically with a tap block. That's important to know because that would be pre-peritoneal, and actually below the white peritoneum you can see intra-abdominal contents moving about nicely. The other way you can do it is by doing a sagittal scan, and here you can quite nicely see the demarcation of Curly's six-pack, which he didn't know he had. The problem with this probe orientation is really nice for threading a catheter in. The challenge is actually the striation of the muscle can confuse you as to which layer's the posterior rectus. So often horizontal scanning is the easiest to orientate yourself before you move into that plane, if you so wish. And this way is a nice way to track your spread of local anaesthetic as well. There's one thing to watch out for with a rectus sheath block, and that is that there are sometimes blood vessels. So we may not be able to see it, but the superior epigastric artery is often found. I'm just going to have a quick scan. I can't obviously see it. You can use color Doppler to find it if you like, but just be aware that it's there. It's often just by the plane where we'd be injecting. Now, classically, you want to inject above the umbilicus, and that's because below the arcuate line, the sheath is no longer continuous. The arcuate line is actually a few centimeters below the umbilicus, and we can see that the sheath is continuous there. But if you stick above it, you're never gonna find a point where so above the umbilicus, you're never going to find a point where the rectus is no longer where the sheath is no longer continuous posteriorly. And that's pretty much it really, and you're going to get nice capsular caudal spread anyway. Now, if we start to move laterally, depending on the height that we are, the muscle that first connects with the rectus is different. So above the umbilicus and subcostally, you'll see that the transverse abdominalis is the first muscle that comes in. So on the right of the screen, we can see the transverse abdominalis coming into view. Then we've got the internal oblique and the external oblique. So move around, and that's the classical 3 lateral wall abdominal muscles. So a subcostal tap block, we'd find the tap muscle at this point and inject in that neurovascular plane above the tap muscle underneath the internal oblique, and you can essentially inject a sausage shape along there. So that would be a subcostal tap block. The more classical tap block that we described would be here. So it starts to look a bit like a torpedo, and you can see that as I move medially in this image, it's the internal oblique that joins first. So internal oblique, and then the 3 muscles there. I've got a little bit of artifact, probably just a little bit more jelly. There we go. So rectus muscle, internal oblique, and then the abdominal wall muscles. So external oblique, internal oblique, and then transverse abdominalis. So really what we want to do is want to go as posteriorly as possible here to do a tap block. So the posterior tap block here, what you're aiming for is this little corner where the transverse abdominalis is ending and the you can see below it, the quadratus lumborum muscle is starting to become apparent. So that's another triangular shaped muscle that's coming in. So coming from anterior to posterior, this is how we do a tap block. If we aim on the screen left of the corner where the transverse abdominalis is ending, that would be a posterior tap block. And if we aim to the side, to the right side of it, that would be a QL1 block. A QL2 block is essentially a very similar injection point, but slightly more posteriorly. So in the middle of the screen now, on top of the quadratus lumborum muscle. But to all intents and purposes in dye spread, I think QL1 and QL2 are very, very similar. And I wouldn't necessarily, as is a posterior tap block, and I wouldn't necessarily worry too much about that. You can see that the quadratus lumborum muscle, I'm not going to scan much deeper to find that here, because I think that's probably beyond the scope. And this is probably the most useful place to do a tap block. So in this block, injection here, it doesn't really matter if it's a posterior tap block, a QL1, QL2 block, you're going to get a very similar cutaneous block, which is subumbilical, good for a fan and steel for cesarean section. Now, we're going to move round to the back now, so I'm just going to give Curly a bit of wipe for his tummy, and we'll get you sat up facing Ash that way. And Ashton. So, moving on to the back, we're going to have a quick look and scan and see the anatomy of the erector spinae and paravertebral space. So lots of jelly, always you can never have too much jelly, and the patient can take more jelly than the pro. The best way to orientate yourself, so here I'm going to have the, to the left of the screen is going to be cephalad. So when we put the ultrasound probe on, you can immediately see just parasternally in the parasagittal view, you can immediately see some tomb-shaped structures. So they are either going to be transverse processes or ribs, and we can confirm either way. So if I scan medially, you see that those, all of a sudden, those slightly curved structures have become more superior and flatter. And if I move laterally, they're curved. So that laterally is a rib, and if we move in medially, it's articulating with the transverse process, and now we're on transverse process. Now, if we move more medially, we will find some point facet, which would be here somewhere. Difficult to see on this with this ultrasound setting, so I won't persevere. Now, when we're on the transverse process, which is here, we can see three muscle layers. The erector spinae muscles, immediately obvious. So you can often see three muscle layers. So trapezius, rhomboid, and maybe a bit low for rhomboid. So here we are, that's better. So trapezius, rhomboid, and the erector spinae muscles. The rhomboid finishes at around about T5. So that's, you can see it tapering off here. So we can tell that that's the T5 level. To be honest, as long as you're identifying the muscle that's over the transverse processes, it doesn't matter too much. So this would be a nice image to do roughly a T5, T4 erector spinae block. And we'll point out on the screen the layer that you need to inject. Now we can count up by going right up to the top, so and then looking for the first rib. So that's first rib, just the left of the screen. Second rib, third rib, fourth rib, fifth. So there, that's rhomboid tapering off. So where we were counting was correct before. Now you can also do it much lower. So depending on the level that you want to go, you can do it anywhere along in the thorax. So you can do in or lumbar. So here a transverse process is much lower down. So to orientate yourself at the bottom, the best thing to do is count ribs. So we've got one rib there, so that must be, and that's a small rib that we can't see that one. There's no ribs below it, so that must be the 12th rib, 11th rib, 10th rib. Fine. Paravertebral space. Yeah. So my preferred technique for doing the paravertebral is to swing the ultrasound probe around. So we have the rib in profile. So if we can get a nice rib in profile here. So we've counted our space. So this is probably it's probably T4 just from where we looked earlier. So if I'm with the rib in profile, I'm just going to slide off it, but aiming to keep the transverse process in view still. So with this image, we have a transverse process on the right of the screen, and then pleura at the bottom, and the intercostal muscles articulating with the transverse process. And you can see there's a little triangular wedge just to the left of the transverse process, which is a bit darker, and that's the paravertebral space. You can also do an erector spinae block in this orientation. So you'd come from lateral to medial and inject on top of the transverse process. An MTP block would be somewhere between the transverse process and the pleura, and a paravertebral space would be in that dark triangle at the bottom. So this is my preferred technique for a paravertebral, and it's a nice way when you're starting to learn to move from erector spinae to paravertebral. The reason that I like this orientation is you have a nice flat needle angle, and a very, very clear, you can see the needle the whole time, and it's very, very clear. Yeah, and that's the paravertebral space.
Paravertebral, Jonathan, because it was much better from here.
Okay, so moving from the transverse process view for the erector spinae, my preferred, I would count the level, and my preferred technique for a paravertebral is to do transverse oblique. So what I'm going to aim to do is get the rib in profile, so we can see here the bright white line is the rib articulating with the transverse process. And if I just slide off the rib, but keep the transverse process in view, you can see on the left, on the right of the screen, transverse process, bright white line with dark below it. No longer a rib, so the bright white line at the bottom of the picture is the pleura that you can see sliding. And above that, you've got intercostal muscles and a dark little triangular wedge, which is the paravertebral space. You can also do a erector spinae from this position as well. So if you come in lateral to medial here with a very flat needle angle and inject on the top of the transverse process, that'd be an erector spinae block. You could do an MTP block, which is halfway between the transverse process and the pleura, and then a slight angulation downwards into the paravertebral space. So when you do a paravertebral, you get the nice dropping of the pleura as a clear endpoint. I prefer this orientation to do a paravertebral block because you have a nice flat needle angle. You can see it very clearly, and you can it's very easy to visualize the needle in the paravertebral space. The danger is that you're pointing at the intervertebral foramen, so you don't want to advance the needle beyond the transverse process at all.
Right.